Hello, everyone. My name is Elizabeth Schwartz, and welcome back to another episode of the 101 Thoughts podcast. Today, we'll be focusing on the impact of RFID technology in healthcare. Emergency departments across the nation have been overrun by patients, affecting quality of care and patient safety. Fortunately, radio frequency identification technology may be the solution. To discuss the topic, I'm joined by Mahshid Abir to talk about the impact of overcrowding in emergency rooms and possible solutions. Mahshid Abir is an associate professor at the University of Michigan Medical School, as well as an emergency physician and researcher. Dr. Abir has made many contributions to the medical field, with a focus on the delivery, quality, and efficiency of critical care. Dr. Abir, thank you so much for taking the time to join us today. To get started, would you mind introducing yourself, just who you are, what you do, and where you've studied?
Sure. So I'm Mahshid Abir. I'm an emergency physician at the University of Michigan and a senior physician policy researcher at the RAND Corporation. And I'm also the director of the Acute Care Research Unit at the University of Michigan Institute for Healthcare Policy and Innovation. I did my undergrad at UCLA Medical School at the University of Cincinnati, emergency medicine training at Jefferson in Philadelphia, and I did a fellowship in health policy at the University of Michigan.
Perfect, thank you. So how long have you worked in emergency medicine?
I've worked in the emergency room for about 12 years now.
What first drew you towards that side of healthcare?
So I love the fact that you can be there for patients when they're most in need, and that you have one opportunity with each patient to have an impact. And I also love the fact that we're the ultimate diagnosticians, so we have to come up with the diagnosis and a management plan very quickly, and sometimes with very little information about the patient.
Very cool. So a lot of what I was researching and what I found had to do with overcrowding in emergency rooms, which obviously is kind of at a high now because of COVID, but it's been an ongoing problem. So with your experience in emergency rooms, have you, experienced overcrowding yourself, and have you seen those effects?
Sure. So I've seen overcrowding in every single ER that I've ever worked in, and I've worked in ERs in various environments in different cities. So in Philadelphia, in New Jersey, in Maryland, in DC, in Georgia, obviously Michigan, which is where I'm right now. So I've never been in a setting where I haven't experienced crowding. And, the question is, how much crowding do you experience in a given ER? Meaning none are immune, I think. I would have to say that probably. But, urban ERs are more likely to be crowded a lot of the time. It does have bad impact. I mean, it definitely decreases the amount of time that doctors and nurses spend with patients. It makes patients wait longer. It probably increases the chance that you may make a mistake or miss something just because you don't have as much time to think through cases. But, I've worked in places where I've seen, 60 patients overnight in an 8-hour shift. And, and intermingled with that are very sick people. So yeah, I mean, it's a very real thing, and it's not good.
Yeah. That's kind of the gist that I got as well, because some of the things that I found that it can spread infectious diseases, because like you were saying, you're intermingling with people that are sick. So, and I guess you kind of explained this, but do you think it has an effect on a physician's ability to work and their ability to correctly diagnose?
Yeah, I think, there's a couple of issues with it. I think one is, again, in a given shift, if you have that many patients or you have a really crowded ER and, a couple of dozen people in a waiting room, you're just going to not have enough time to think in more detail. And also, I think eventually, especially in places that experience crowding a lot, it leads to, I think, burnout. So, the average lifespan of an ER doc's career clinically is 8 years, which is, this is a little bit of a dated number. I'm curious in the more recent years what that average is, but that's part of the reason is just pure, when you're there and it's just really intense no matter what. And if it's busy, then eventually you're going to burn out. And that's unfortunate because the healthcare system and patients lose, when you're losing practitioners due to burnout and exhaustion, essentially.
Yeah, that's kind of crazy. I've definitely heard about burnout, but 8 years is pretty short. So I found one of your articles. I believe it's called The Association Between Hospital Occupancy and Mortality Among Medicare Patients. Correct me if I'm wrong, but from what I got out of that is that you found that higher admission day occupancy and higher discharge day occupancy were associated with decreased patient mortality. Is that right?
Partially. So we measured two types of mortality. So inpatient and out-of-hospital mortality. So basically, whether a patient dies while they're still in the hospital or whether they're released after they're released. So we found that you are less likely to die in the hospital if you're admitted or discharged on a crowded day, but you're more likely to die out of the hospital. And our theory is that because the hospital gets crowded and doctors are pressured to discharge patients when it's busy, that you're doing one of two things. Either you're discharging people who would have died in the ER, in the hospital anyway, and you're shifting those deaths to the out-of-hospital setting, or you prematurely discharge someone who could have actually not died. so that, it's one of those two things. So, and, ED crowding, as you may have found through your kind of review, is really well studied, but kind of this phenomenon of high occupancy or crowding on the inpatient side has rarely been studied. So there's very little data around it. And in fact, the idea for that project that you just cited came from my own experience of ED crowding, and I knew the literature showed that there's all sorts of bad things that happen when ERs are crowded. I was like, so what about the inpatient side? Because the health system is a closed, it's closed. Ultimately, it's a closed system, right? There's only so much you can add into it. And, if the ED is crowded, that means that you're probably admitting more people and the inpatient side is going to be crowded. So that's how that all started. But it was a very interesting finding to see that, ultimately, actually, when you looked at all of mortality, inpatient and outpatient, I have to go back and recall, but I think that at the end of the day, the decrease trumped the increase. The decrease in the inpatient setting trumped the increase in the out-of-hospital setting.
Yeah, that's definitely very interesting. It's kind of, I guess, not what I would have expected. So it's definitely some interesting results.
Yeah, same here. Yeah, we were surprised by those findings as well. And one of the things that we thought is, are these health systems or hospitals just functioning more optimally when they are busy? Do we do better when our plate is more full? And there's some evidence to show that may be the case, but at the end of the day, it's probably multifactorial, and future studies need to kind of try to replicate what we did in other states and maybe do some qualitative research to figure out the underlying causes of what we saw.
And that was published in May. So is that done here at Michigan?
So that was done, yes, the study was done in Michigan and with the RAND Corporation, and it was using data from hospitals in California, so almost 400 hospitals in California.
Okay. So you've kind of mentioned it a couple times, but you've been working with RAND, and more recently, you've been trying to identify effective critical care response tools to help with the COVID crisis. Is that right?
That's right, yeah.
Okay, perfect. Do you mind just going through some of your findings and some of the most effective tools that you were able to find?
Yeah, so it's so interesting that you've linked these studies. You're asking all the right questions. That's very impressive on your side, because this is random articles, but you managed to kind of trace what they have in common. So so this is a project that RAND funded in the spring, in the early part of the pandemic in the U.S. And so the idea was, we know that at baseline, critical care is a commodity in the U.S. And, what are some strategies to increase critical care surge capacity, given that a lot of patients who are hospitalized with COVID may end up in ICUs and on ventilators. And basically, a couple of things that we learned is that, first of all, for the scale of surge that you need to respond to this pandemic, especially if you're a pandemic epicenter like Detroit or New York City, and now, a lot of places across the US, are experiencing major challenges, but you really need to almost use all the surge tools that you have, and perhaps even use them concurrently, and even go beyond what you would ever imagine doing, what your previous kind of surge plans dictated, because we never thought that we would see this long of a surge necessity, this degree of a surge being needed, and then a surge in so many different places concurrently. So the biggest message, there's many messages, but for the purposes of this call, I think the most important thing to communicate to you is a need for regionalizing, response to the pandemic. And by that, I mean that in every state and every FEMA region, so Federal Emergency Management Agency regions, there is a finite amount of resources, let's say for critical care. So critical care nurses, ventilators, PPE, which is personal protective equipment, all sorts of different medicines that are needed for critical care. And if in a region you have one or more epicenters, we should have mechanisms in place for the places that have the resources, share those resources with the places that need it the most, or alternatively, patients should be sent from epicenters to non-epicenter hospitals or health systems. And in order to kind of really diffuse the kind of need for resources, instead of it all being focused in one place and kind of decimating one or more health systems in one place. So we have mechanisms to do that. And there's FEMA regions, there are healthcare coalitions, there are, state departments of health. There's other networks that can be leveraged to, in advance, plan for such kind of exchange of resources or transfer of patients. We do transfer of patients a good bit, and even during routine situations, from places that don't have the specialty care or the needed resources to other hospitals. But we also have to have plans in place to be able to ship staff and stuff like ventilators to places that need it a lot. And hospitals need to do that now. And in fact, it's probably already, they should have been doing it weeks ago, where they work with coalitions and hospital and health systems within the state or their regions geographically, so that when they need these kind of swapping of patients or resources, that they have them kind of like MOUs in place to make it happen quickly. Because, otherwise, so hospitals won't be able to take care of their usual patients. People won't come to hospitals, even if they have chest pain and maybe they're having a heart attack. And that's why we're seeing such excess mortality. All-cause mortality has significantly gone up, not just in the US, but many other places across the world. So that's probably the biggest message I'd leave with you is from that work is the need for regionalization. And it hasn't happened yet. And it's very unfortunate because we have the tools, we have the science, we've planned to do that kind of thing for a long time, and we're just not leveraging those kind of resources.
So that's interesting. That hasn't happened anywhere?
I don't know that it hasn't happened anywhere. So certainly transfer of patients from overwhelmed hospitals to hospitals that have capacity, specifically to ICUs that have empty beds, that certainly has happened. But I think that this kind of like systematic, pre-planned hospitals within a region agreeing to have each other's backs. I don't know that that's happened. I'm not aware that it's happened anywhere, and that's how we really need to start thinking about responding, because today it's Detroit, tomorrow it may be Ann Arbor. And if we don't have each other's back, no one's going to win. And, unfortunately, a lot of hospitals that are in geographically proximate, they're competitors at baseline. So it's very hard for them to think in this collaborative way during an emergency.
Got it. And that's an ongoing study, right? Or is it kind of concluded?
So that part of it is done with. So we did that in 3 weeks, and it was published in April, actually, so pretty early on. And now it's receiving new attention again because of the relevance, unfortunately. So we are considering some follow-up work on it, but to be honest with you, many of the recommendations are still incredibly valid, but quite unfortunately. So I think there's much work to be done, even based on just that report and the tool that was published along with it. And we're probably going to do follow-up work as well related to that.
That's very interesting. And would you work to promote some of the strategies, like the regionalizing? Is that something you would do and your team would do, is promote that to hospitals?
Yeah, so interesting you asked that, because I think that, so when this was published, the report and the tool on the RAND website, within the first 2 weeks, we had, I believe, 4,000 downloads of each, which is, a big number. There's about 5,500 or so hospitals across the U.S. So, I think that probably, and based on other data, we believe that it's mainly hospitals that have kind of potentially this is on their radar, but it really needs to be policymakers at the end of the day at the state and federal level. And that is actually part of the follow-up plan, which we need funding for, and we're actually actively looking for funding, is to take what we've done before, build on it, and explicitly kind of prepare a report that is meant for policymakers.
Okay, that's very cool. All right, kind of shifting gears a little bit. Are you familiar with radio frequency identification technology, or RFID?
I am. Yeah, I am actually. But I have to tell you that in none of the places that I've worked have people used it on a routine basis. Mm-hmm. And I'm only aware of it in the context of some pilot studies on the inpatient side. And I know it's done in the ER as well, but I've never practiced anywhere that uses that technology.
Yeah, that's kind of what I've been finding too, is a lot of what's happening right now is still beginning stages of implementing it. So a lot of what I found, the benefits of RFID, is that it's wireless. So right now in a lot of hospitals, it's wristbands with the barcode you scan. Is that right? On patients?
Honestly, I don't know. I don't know about the current status of the technology or how they're using it. I really, don't know how they're using it. You probably know more about it than I do, because, yeah. And I mean, I can imagine how you can use it to keep track of time for tasks and movement of patients, so that you can reduce wait times or lag times and become more efficient. But beyond that, I frankly don't know more about it.
All right, perfect. Thank you. Well, I don't really have very many other questions to ask. Do you have anything else that you would like to add?
No, it's just really refreshing to see you reaching out. It's really kind of very interesting that you picked this as a topic. And this early in your education, it's really impressive. So good for you. And if you ever kind of have any other questions, please, where to find me. Happy to answer other questions.
Perfect. Thank you so much again for taking the time. You were very flexible. So
absolutely. Take care, Elizabeth. Bye.
Bye. Thank you.